So, hello, Thompson. We already did a short interview back in 2019 about low back pain, and we're going to dig a little deeper today, right?
Indeed. It's great to see you, Jacqueline. Yeah, that was back long before the pandemic. A lot has changed since then, but it's great that we're getting on with life now and things are getting back to normal. So yeah, it's great to see you. Yeah.
Same to you. So why are we talking about low back pain? Why is it so important?
Well, I think from a physio's perspective, low back pain is possibly low back and neck pain or spinal pain is probably the most common thing that we see. Certainly in our clinic, low back pain, neck pain, shoulder pain, they're the three most prevalent things we see outside maybe of the presented tendinopathies. But low back pain has a huge burden on society, both socioeconomically and of course on people and individuals in terms of their pain and potentially their understanding of that pain. Back pain is just very common. It's a human problem. Yeah. Most back pain is not serious. That's what's important. Most of us will get through our back pain, and back pain is not shouldn't really worry us in most cases. And I think that's one of the main things about back pain in society is educating people that lifetime prevalence is common, but people get better. And there are different types of back pain, different severities. And I think sometimes from a clinical perspective, back pain is overcomplicated in many respects. Now, there are complex back presentations, but I think some of those presentations are complex because of the way society sees back pain, and perhaps also from things like the medicalization of back pain, imaging, and the talk of surgeries and interventional medicine. Though they have a role, it's with a small subset of people. So I think there's a disconnect maybe between the reality of back pain and the medicalization of back pain. And I think because we see so many people, and lots of what we can do as physiotherapists, particularly, is educate people.
Yeah. So what are the different causes for low back pain?
Well, I think in looking at, say, Gordon Waddell's argument that really 90% or 80 to 90% of back pain is what they call simple back pain, or non-complex back pain maybe. Within that group, potentially, sometimes you won't have a diagnosis, and you can treat without a diagnosis. And we'll come back to that in a couple of minutes. But certainly within that subset, there is pathoanatomical pain and maybe non-pathoanatomical, or we can't find maybe any causes of that pain. But within the classifications, we have certain diagnostic tests we'll come into later, or we'll mention those briefly, that may help us to look at the prevalence and the presence of the likelihood ratios of, say, discogenic facet joint mediated pain, sacroiliac pain. Of course, the hip is a very common source of low back pain, and hip pain, groin pain mimics sciatica sometimes, or mimics radiculopathy. It needs to be a differential diagnosis. Lateral hip pain would also include things like trochanteric syndrome, gluteal tendinopathies, and of course then muscular back pain. Muscular back pain, I think, is very prevalent. And often when we go through the assessment with patients, we don't have a very clear picture. Perhaps all they present with is primary myofascial pain. Outside of that, of course, we've got what they would consider the more serious back pain. And, of course, we're talking about tumors there, cancers, which prevalence wouldn't be particularly high, but we'll be talking also about the radiculopathies, nerve root compressions. And they maybe range from maybe 3 to 10% depending. And then, of course, we've things like inflammatory back pain, which would include, say, the ankylosing, autoimmune disorders. And then, of course, we've traumatic back pain, which, you're looking at road traffic accidents, work-related accidents, perhaps falls, particularly slips, and of course sport, impact injuries. So that's kind of the main, but there is a move in the past, to move away from the term pathoanatomical diagnosis. But if we looked at the ankle and we have a test, say, for an x-ray, and somebody has a fractured ankle, that's a pathoanatomical diagnosis. But the argument in back pain would be if you have a test that gives you a reasonable probability of the presence of discogenic mediated pain, then I think it's reasonable to talk about that. And I think it's reasonable to say that to a patient. But I think we shouldn't get hung up too much on the pathology as much as maybe particularly in those, simple back pains or the non-serious back pain.
Yeah.
Maybe some of that is just looking at function and looking at outcomes rather than purely labels. I think that's maybe more important.
Maybe that's also better for the patients if they don't really focus that much on their diagnosis, right?
Absolutely. And that's, I think there is that disconnect. Maybe we need to disconnect from the imaging. We should treat the person, not the scan.
Yeah.
Now, I'm not saying scans are not helpful. This week alone, I've seen a T6 fracture in a 39-year-old.
Yeah.
And certainly that is the diagnosis. That's where imaging becomes important. But then again, I saw somebody else who presented, and the first thing they showed me was their scan and said, I've got wear and tear or degeneration. Mm-hmm. But it doesn't necessarily mean that's the mediated pain profile. And of course, we need to be aware we can have pain, nociception in the tissues, and we can perceive pain. We could have nociception and we don't perceive pain. Yeah. We could have no tissue nociception, but we could still perceive pain. Because, of course, we have to think about the periphery and the central nervous system. And, of course, the psychological aspects and the modulated aspects of pain.
Yes.
I'm not hugely into separating the two necessarily. For academic and discussionary purposes, that's important. But people are people. People have an ankle, people have a back, and people have a brain, and they're connected. Yeah. But I think sometimes, of course, it's important to look at the biopsychosocial model. I think sometimes we've forgotten a little bit of the biology and we focus on the psychosocial, or vice versa. We look too much and blame the biology. But I think in individual patients, we can be driven by a better approach by the biopsychosocial model and taking into account, really higher centers. Yeah, of course.
But I think that's something that we can also assess in our anamnesis with the patient in what direction we want to go.
Yes.
And afterwards, of course, we are going to look at range of motion and stability. But are there recommendations on which assessments or tests we really should use with low back pain patients?
Well, there was a study actually out of, I think it was the Benelux countries, was it maybe Belgium and the Netherlands, and it was a study of maybe 900 people who went through a chiropractic clinic. Now, the guy Ale, I think it was 2016 perhaps, and he looked at 900 people going through with back, neck pain, and headache through clinic. He's also a physiotherapist, published in Physical Therapy Journal, and they basically said. In that group, measuring the socio demographics made no difference on the outcomes.
Yeah,
actually didn't have any impact on the outcomes. The Nice Consortium guidelines from the UK suggest formal psychological approach if not doing well or if failing physio, or if there's a specific reason you can identify early on.
Yeah,
it's not saying that psychosocial isn't important, but if we do a random controlled trial today, we walk into the room in a white coat, we can't speak, we do something and we walk out, for instance. That's not how physio works.
Mm-hmm.
I know my patients. I had a patient back recently, and I know a family member had passed away, and we spent the first 10 minutes talking about that. We interact, we coach, we cajole, and we interact with our patients. Much of the biopsychosocial is within that context of the patient contact.
Yeah.
I certainly would be I would use a lot of the, for instance, modified oswestry, the neck disability index.
Mm-hmm.
So I'd use maybe the functional scales more, but I think the fear avoidance scales and catastrophization scales may be helpful.
Yeah.
But I think on the whole, for the general practice, I'm talking about general practice here of physio, probably just blending that in with the whole treatment approach is probably the best way, and maybe to go more formal or to look at pain specialty beyond that.
Mm-hmm.
Our physios who particularly work with persistent chronic pain may be helpful.
Yeah. And how do you differentiate between, is it the hip, is it the sacroiliac joint, or is it really the low back that's making the problems?
Yeah, so I think, first of all, the interview is hugely valuable. I mean, that's where the interaction is. That's where the, I think within the experience and the context of physios, we can apply guidelines. We can apply guidelines that somebody have written who hasn't seen a patient in 20 years or 10 years or whatever it is. But I think the importance is we shouldn't underestimate the value of expertise within the clinical setting. For some reason in physio, it's suggested that expertise isn't as valuable, or we're full of bias. But we wouldn't say that about the surgeon who's done 4,000 hip replacements, or we wouldn't say that about the pilot who has 10,000 hours of flying. The same thing with physio. I think within the assessment, the expertise is very much built in from the experience of interviewing patients and learning what becomes valuable, the words they use, like fear avoidance words like danger and harm. I don't exercise because it might harm me. So I think moving into that, when we're going into the physical assessment, we have a fairly good idea. First of all, what is the pain profile? How did it start? Do they have pain anywhere else? Is it nighttime pain? Is it inflammatory? So moving into that, then I would usually start just with a quick postural review of their back. But of course, posture wouldn't necessarily dictate pain, because we can have great posture and have pain, and poor posture. But the habitus of the patient, are there difference in levels of back muscle tone? Then usually I do a McKenzie assessment, repeated movements. And that's been shown to be valuable for the assessment because it's a pain provocation or a pain relieving test. And if you have a preferential direction up to 5.9 times predictive of discogram, and if the person has centralization, they show up to a 7 times greater likelihood ratio of positive discogram. So I would do McKenzie first. About 40% of back pain patients will probably show McKenzie preferential direction. And that's going to dictate my treatment. Top of the food chain at that stage. I'll screen the hip with the quadrant test, and there is a clinical prediction rule for the hip, particularly for OA, the profile of the patient. Can they put their shoes on? Internal, external rotation, especially. Sacroiliac, the tests there's Laslets, the SICK complex composite tests, but they showed up to nearly a 5 times greater chance of predicting a block for the SIJ. But a recent study maybe contradicted that. I'll do the active straight leg raise, which is the Fleming test. That would be a whole day's talk. Andre Fleming is a fantastic physio. That's a great Menzen Fleming test, the active straight leg raise. And it's got a good validity and a good reliability. Of course, going back, I would do the straight leg raise. Straight leg raise is indicative of nerve conduction and EMG tests. So it tells us about the health of the nerve. It's not foolproof, but it's very good. I'll do reflexes, myotones, check those. The pain referral pattern could be helpful. After that, the facet joint. Difficulty with the facet joint is there's no clinical test to rule it in. More than likely, there's physical test to rule it out, that if the extension rotation is clear, you can probably rule it out. And there's a body of literature or a body of research on that, but we can't rule it in. And the only way to rule it in is by diagnostic block. So with the facet, but the profile of the patient is usually age over 55 or a history of trauma. So looking at those in terms of trying to look at maybe a classification within those certain structures. But again, you may not have a clear picture. Or they may have two things. Trochanteric bursitis, do they have pain over the lateral hip, the sleeping aspects of it? And then, of course, the myofascial pain. And I mean, that's just so prevalent. And coexisting with those other diagnoses.
The other ones,
or those other presenters, And of course, sometimes, as I said, the picture isn't clear. And I do think that once there's high disability, high fear avoidance, you might find all tests being positive. Or so and Laslett did say that in one of his studies. He did say if there was high disability, it reduced the power of the likelihood ratio for discogenic pain, for instance. So I think high fear avoidance, high functional disability are not great predictors of long-term back pain. And the argument nowadays is perhaps the avoidance of the movement, not just the fear. So if somebody says they fear it, but they do it, they're probably going to be better than somebody who just doesn't do it and fears it.
Of course. So we already heard patient education is an important aspect of our treatment. What else is recommended in studies or evidence-based?
Well, up to a number of years ago, one of the things was that particularly that 12-week window, and why was there a 12-week window? Why did they consider the 12 weeks? I mean, who came up with 12 weeks? It was linked more so, I think, to tissue healing concepts, like bone and ligaments, tendons, by 12 weeks, lots of people are better. But it seems to be fairly predictive. So about 80% of people will recover by 12 weeks. Now, many of them will have a reoccurrence, and that maybe can be prevented by things like exercise. Yeah. But in that first 12 weeks, it appears that education is quite effective when repeated. When you go outside of that 12-week window, there was some research to say education may not be effective or as effective. Certainly one study said it doesn't work, but that doesn't mean you don't do it. Because so I think education would be number one, interacting with the patient. The second thing is exercise. I think that's the important thing for back pain is exercise. Now, some things can be specific, like McKenzie, I think, needs to be specific. So I would be very much into, do your McKenzie exercise. But in terms of strengthening and outside of that, there's so many things that can help. Pilates, yoga, Tai Chi, exercise, swimming, cycling, walking, increasing load. But I think what's also important within that is to pick the patient's preference, or to indicate their preference and get them to rinse and repeat. And repeat. Exercise certainly is important. Exercise has strong evidence. It works for back pain. Strong evidence means the evidence keeps repeating the same thing, saying exercise works. Loads of different types. But the side effect of exercise may not be brilliant. And we need to be careful with that with patients, because we often say, the strong evidence exercise works. They think we mean this is going to be a strong effect. So we have to be realistic with them and say, look, if you're going to go on a walking program, your back pain's not necessarily going to be gone in 6 weeks, but it can help, and it can help a lot. And it really is the top of the food chain. After that, I would think then you're talking the manual therapies, manipulative soft tissue, lots of, not lots, but a good number of researchers showed up till 2008 that soft tissue was effective at the long term. Then Cochrane came out in 2015 with larger group studies, 24, I think it was, and they actually switched that opinion and said, look, it appears that it's effective short term, up to 12 weeks. But I think people talk about windows of opportunity, but I think passive treatments or hands-on treatments are the additive. But we also need to take into account that if somebody is doing an active treatment like exercise, we should focus on that. The difference with a passive treatment, it was done. The passive treatment was delivered. Lots of people don't do their exercise. Other than exercising. So it's fine to have all the literature showing back pain and exercise is effective. But if the patient's not doing it, then it's not even an active treatment.
So what is the role of trigger point therapy and dry needling regarding low back pain?
So in regards to low back pain, the prevalence of myofascial pain has been seen to be quite high. Particularly, there are many muscles. I can't remember. I once counted, or was it 19 muscles that potentially referred to the back? Within those, there are probably 3 or 4, particularly the erector spinae. And I would strongly argue the erector spinae in the lower thoracic junction, the T80, 90, 10 area, often hypersensitive with referral down to the low back, lumbar, SIJ area. Secondly, would be quadratus lumborum, as Travell called it, the joker of low back pain. And then the third one, sitting in there, of course, is glute medius. Glute medius, we all learn anatomically as being lower limb, but it refers to the back, and highly prevalent in back pain, and actually highly prevalent as dysfunction in back pain. Strengthen the glute medius, people usually a better back function, and hip. And then the fourth one being the multifidus, but a lot of people surprisingly don't have a sensitive multifidus, but lots do. And so those would be the 4. And the more trigger points present, the more likely the person had higher pain and higher sleep dysfunction, as shown by the studies with, I think it was Cesar Fernandez out of Spain. So treatment of those, I think, either if somebody has primary myofascial pain, that's all we're kind of finding. my treatment is just based upon trigger points coupled with exercise. And that would almost always be manual therapy first, because I can assess them, find where they're sensitive. The first day you're palpating trigger points, people are saying, my God, that's so sensitive. Never knew it was so sensitive. 2 or 3 treatments in, they're now talking about the weather or the dog or life, and they're not as sensitive. Now, you can use a PPT meter to measure it. Use your, physios, as we become more versed and more expert in it, we understand our pressure relationship, and we understand what's low and what's high, etc. And we learn that, and you can learn that off the meter. So I would use manual therapy primarily 5, 10, 15 minutes. We're not talking long time.
Yeah.
For the multifidus, I would normally then just come down the spinous processes, palpate either side of the spinous process, moving down along, trying to find the most sensitive area, and then pressure release on whatever muscles are relevant to them. Second of all, then there's dry needling. And a couple of studies did show, for even people with discogenic pain, that adding dry needling to a McKenzie program was superior to McKenzie alone.
Yeah.
So the role of dry needling then, I think, as physios, our own experiences and taking that into account or not, we tend to see dry needling as working longer and better. It's certainly an experience of mine, but I don't think manual therapy should be overlooked. I think it's hugely valuable. And of course, with many patients, it's both. So it's the specific and non-specific. So I think we see very good results with that. Often a window of opportunity, people are starting to show improved function. That's the time we really need to be telling them, you start to get moving, you need to get moving, build fatigue resistance of these muscles with exercise. So I think that's the key element. Almost everybody with back pain, I will probably palpate their trigger points and treat them. SIJ patients, facet, etc. Depending on that, the hierarchy of the treatment, McKenzie will be up top. These are then supportive or helpful treatments, particularly for the pain. And there's good evidence, dry needling and manual therapies are good, particularly in the short-term windows. We have some patients who come intermittently. They get, one lady, I'm just thinking off the top of my head, has headache. She's off all medicine. She'll come for physio every 8, 12 weeks. She has 90% less headaches now, and she finds dry needling will work up to anywhere from 8 to 12 weeks for her. But she's willing to do that rather than take medicines. 15 years she was taking medicines for headache. So I think the benefit of dry needling and manual therapy shouldn't be overlooked as part of a wider package of care. But of course, we should be effect-based. Are they improving? Clinical reasoning. But I would dry needle lots of people with back pain. And that's always, I don't think it needs to be too,
sorry?
Yeah, I don't think it needs to be too complex. Those 4 muscles are the common ones. And being able to needle those, I think, is very important in back pain.
And as always, multimodal therapy or treatment is better than only one.
And I think the important thing we should keep, in terms of dry needling, we should keep training. Dry needling grew from injection therapy. There's a body of evidence behind it now growing, both biological, both, and random controlled trials. Hard thing to study, but there is increasing evidence. I think we should also keep it real. That I see some things on social media where there's a lot of stuff going on and claims for needling and this and that. I think we should keep this real. That dry needling is helpful for muscular pain, for pain modulation, and certainly we should keep it within that scientific framework. But some of the stuff I see on social media, does surprise me, and in some cases I raise my eyebrows. That we shouldn't make, and it's not necessarily physios, and certainly I don't see them from Ireland here, and certainly I'm sure you don't see that in Switzerland. But there's a certain aspect that dry needling is seen as the new thing, and needles put in everywhere. Of course, this is around a long time, and I think we should keep it within that medical procedure. It's a medical procedure, and I think that it has a rational basis, and it's part of multimodal care. So I think in terms of back pain, certainly education, exercise, manual therapies, but exercise probably being the biggest part of it. It would be, I would do even balance exercise with low back pain patients. and certainly Pilates, yoga, but general exercise shouldn't be undervalued. It's very powerful.
Yeah, and I think the preferences of the patient are really important, because then you get them moving. Otherwise, if they have to do something that they don't like, they won't do it.
Yeah.
But
in terms of, say, dry needling and those trials, we did have the attempt at the placebo-blinded trial in the placebo-blinded trial by Orlando de Moral and the group in Toledo, in Spain, I think published 2010. And they did dry needling on people about to have a knee replacement who were anesthetized and they shammed one group and they dry needled the other group. That showed a profound difference. So we do have the placebo blinded. That it's an attempt at placebo. It's very difficult. But when you placebo low back pain, so exercise for low back pain, I mean, how do you placebo exercise for low back pain? So maybe you say, right, we placeboed against ultrasound. But some recent studies have said when you do that, the size effect is massive between a placebo treatment and exercise. So we have to be aware that, even the thing we see as a gold standard has a lot of difficulties and questions over.
Yeah.
Still, exercise, I think, is the top of the food chain. For most cases. Yeah.
Of course, there is a huge gap between this evidence-based practice and our reality as a physiotherapist.
Yeah, and that's I think where really the word evidence informed. And I think the problem with evidence-based practice is, like anything in humans, it was never meant to be random controlled trials or systematic reviews alone. It's a hierarchy. And the problem with that is, for some reason, level 1 and 2 are level 1 only. So somebody goes and reads the level 1 systematic review and they believe it, or it becomes their panacea. The problem is those studies may have been so different or heterogeneous that you can't even compare them, but yet they were compared. So there's a problem with systematic reviews as well. Evidence informed, the clinical reasoning, the patient's belief, wish, and desire. We now know that patient expectation drives outcome. And we know that in acupuncture studies, and people will say, well, that's just really placebo. But now we have a paper that was published only recently that showed there's a neuromodulation in that. You can actually see the parts of the brain lighting up within that expectation. So that maybe expectation is a huge driver of outcome.
Yeah.
So the first thing we need to ask as physios is, the first question I'd ask is, how did the patient come to be with you?
Yeah.
Who referred them? Was it a family member who said, you need to go and see Jacqueline because, she was very nice and she really helped me? They're already expectation enabled when they hear that. The doctor says, there's a great physio 2 miles down the road. I'm going to recommend you go and see them. With great results. Patients are very happy with them. And results don't just mean range of motion, pain pressure thresholds. Results are really, what did the patient get out of that interaction?
Yeah.
Lots of patients are happy with the interaction with physios, but they may not be cured. I don't really like that word, but so I think maybe how patients come to see us, how their expectation enabled. So if you're really good at something, you probably attract patients who like the fact that you're good at that.
Yeah.
So lots of trials haven't even addressed those factors. So I think expectation, and we shouldn't underestimate that. That's not something soft. Expectation is a big thing. And I would find that the patients who are more compliant, they're more likely and interested in therapy. Often, though, they can be predicted by the ones who have higher function and less fear avoidance, though, I think, as well. So it's a complex web. But I think the interaction with physio and patient is potentially the therapeutic value. And when we center around the individual patient, I think we get much better outcomes.
Yeah.
And certainly some studies have shown that, so I don't think we should be treating by random control, systematic meta-analysis alone. I think they're important, but I think that, we need to see everybody as individual. We need to problem solve.
Yeah.
We need to problem solve.
Yeah.
And sometimes we need to take that problem and educate patients that it's not such a big problem. And I think that's,
of course,
maybe half the battle. Yeah.
Is this your take-home message, that we should really focus on the patient and on the individual needs?
Yeah, I think that's what I would think is the take-home message. I think is that, as physios, we're scientists. science has increased in low back pain, but low back pain has increased. So what I'm saying is that the more science we've done, I'm not saying they're correlated, or they're certainly not maybe causated, but I'm just saying that maybe the medicalization of people. So that's why maybe we should cajole and coach those patients. Tell them, I see people with this all the time and people get on with their lives. The desensitization of the experience for the patient. So I think putting the patient at the center is very important, using science around it. And I think, not to sound, as people will maybe consider this old-fashioned, but science in physiotherapy is an art. I think maybe when we really realize that and apply the science in an artistic way, I think we have better outcomes. I think patients are happier, and I hope physios are too. And that's why I like presentation of things like guidelines, but guidelines are there to guide you, keep you safe. Maybe that's important. Yeah. But I think the other aspect of guidelines is to give you a framework, but that framework may not work or may not be appropriate for X, Y, Z. And I think, and this is something we need to study more in physio, is how do experienced clinicians apply these tangible and non-tangible aspects of treatment. So my take-home message would be treat the patient.
Yeah.
Treat the patient. Or maybe the other thing I'd say is undertreat, or treat them. We don't need to overtreat them.
Yeah.
But treat them and use all the things that we've got within our toolbox for that individual patient to get them from A to B or wherever they want to go. Or maybe to assist them in their journey, but also maybe to redirect them in that journey and explain to them that, back pain it's not a sentence, and I think that's, and this applies to neck pain. This applies to shoulder pain.
And actually almost to everything, right?
Yeah, and tendinopathies, and yeah. So it's not just, and I think, we need to look at, of course, those brain aspects, sleep. We need to look at, the stress responses within patients. We need to look at exercise. All of that needs to be looked at, the central and the descending inhibition pathways, and lots of that through cognitive, discussions, interaction with the patient, information. Maybe, Google's a great thing, but it's also a fear factor for people,
yeah.
on social media. So trying to set the record straight for them, or assist them. And I think maybe moving away like that with pathoanatomic, move towards it if it makes sense, but don't focus on it too much.
Yeah.
But move away from it also if it's not appropriate. But I'm all for appropriateness. Yeah.
Yeah, and treat them. Thank you very much.
Yeah, look, come here. It was absolutely fantastic. And thanks so much for taking the time. Yeah.
Thank you.
Thanks, Jacqueline. Bye-bye.
Bye.
Yeah.